Good morning, everyone. First, I just want to say thank you. This is the first time I've been here, although John and other folks have been trying to get me, folks know Dr. Susie Button. She's been trying to get me here, I think, for 5 years. But I work for the New York State Department of Health, and if you know government, which I know many of you know, last year I got approved the day after the conference started. So this year it was tight. I was under the wire. And I'm not really in your program because they didn't know if I was going to be here. So I'm really excited to be here. I have learned so much. Isn't this conference awesome, right? So I think I've given my business card out about 4 or 5 times. Please call me. Please help us. We need help. I also just want to thank my team. Obviously, they couldn't all be here because, the approval process. But I have 2 great employees, Diana and Faith. And Faith is also a parent who presented, so thank you guys. And then we could not do any of this work without John, April, Olga, the whole team, Brendan, Randy. I don't know what I'm calling him today. And then Dr. Button, who started us off. And I'm just really impressed that we're here, to be honest, with New York State red tape. So I think we'll get going. And I hope, is this the clicker? Okay. This is very cool. Look at that. Looks very tech savvy. All right, so I will try to do my best here. So I just want to talk about what we've been doing, and I am very excited about it, and I know Susie's in the background going, holy crap, I can't believe you accomplished this. And sometimes I'm not sure, but so maybe some of you are aware of of health home programs that was put out by the federal government. So in New York State, we did this whole Medicaid redesign. So the health home program is in the Medicaid program. And we really wanted to cut cost, really. High cost Medicaid and really not so good outcomes. And there was a whole children's committee from an array of stakeholders, and we really wanted to get better outcomes and lower the cost of Medicaid in our state. And we really had lots of discussions, again, with so many stakeholders, including parents and families and children, to really look at what the issues were. And I think it was Maryland that had the silos. So we say we broke down the silos, but we have like a silo within the broken down silos. So it really is very difficult to work. I'm sure you all have your own challenges as well to, really be collaborative with so many different stakeholders who have their own focus, right? And everybody wants to take care of their children. I think we're almost to, they're all our children that we're all working for. To lower costs and look of how we could do that. And so in 2012, we launched our adult health home program. And in 2016, we launched our children's health home program. And in 2017, we actually launched a health home program for our Office of People with Disability Services. So there was this motto that it was care management for all. And the goal that we found was so many Medicaid patients just weren't linked to the right services. Many of the kids didn't have pediatric care or pediatricians. Adults didn't have primary care doctors. And so the goal was to really link them to proper care. And then once you're linked to community providers, then you would be more successful in a crisis or something like that. So The health home model in New York State for children is really about children who have chronic conditions, behavioral health, mental health, as well as physical health. And so you have to have 2 chronic conditions, or what we call a single qualifying condition. So HIV/AIDS. We just added sickle cell last year as a single qualifying condition. Serious emotional illness for our adults, and SED for children. And then we also added complex trauma for our child welfare system, because some of our kids don't really fit neatly when they come into the system, into one of those buckets, so complex trauma. So you need to get eligibility through the chronic conditions to join our health home program. It's not population specific or from a certain organization or service array. The other thing is you can have chronic conditions, right, or behavioral health needs, and you could have that for life. So we also wanted to focus on children and families who also not only met the criteria, but really needed care management. So we have what's called an appropriateness criteria. So we really wanted to do some intensive work with families, and then hopefully help to, create some self-sufficiencies or linkages to the right providers so that they could continue to help them and they could leave the program. And then they could always come back if something was happening and they needed care management again. So we have this appropriateness criteria. And you'll see, I think it's the last one, we have if your caregiver also is in a health home, or so we just know as a family, right, it's very difficult for children sometimes if their family members, caregivers also have, chronic conditions or other needs, that they should be able to get into a health home as a family member. And then we have what's called the 6 core services, and I won't go over them too much, but this is what a care manager is focused on. First, we call it comprehensive care management. So they're really looking at overall everything that a child and family would need. So I keep hearing the story, right? So this is the job of the care manager, to get that story and make sure that they are finding out where some deficits in services or linkages, what is the needs and the strengths of that kid and family. And then obviously health promotion is one of our key core services because it's related to the chronic conditions. And then transitional care is the biggest one, I think, because I think this is where we lose folks, right? When you're stepping down from a hospital or a residential center, how many people know that, you leaving a hospital, you get a bunch of papers of referrals, right? And it's really difficult for families to, first of all, remember everything the doctor said, and then have all these pieces of paper and then expect to follow up with people. So our goal with care managers is they make that linkage. They make sure that you understand what you need to do next, and then they help you get to that next step when you're stepping down. And then we have patient and family and support. So again, so many times people just need that supportive person. So we have a lot of services regarding peer and family supportive services. And then obviously the big linkages to other community supports, so they can be aware of what's in their community. And then the last is about technology. We always build new systems, and we have, EHR systems and computer systems, and they don't talk to one another, right? And you're like, how do you get this data? So our goal is to try to make sure that technology can talk to one another, and then also be able to get the data out of that system to measure performance. So what does this have to do with the cans? So we wanted to really, as I mentioned, how do we assess and determine what are the needs of kids? So we did a look across our state of what we were using. In many of our programs, smaller programs, were using some kind of version of the cans. So when we had this huge stakeholder group and we were looking at tools, we decided to look at the cans and worked with John. That was actually before my time. And we developed what we call the CANS New York. So we modified the CANS tool to fit our needs for our program and made sure that it captured the type of children and families that we wanted to work with in the Medicaid program. So we have two tools. We have the 0 to 5 and the 6 to 21 ages. It's in an electronic platform of ours. It's called the Uniform Assessment System. There's a lot of our Medicaid assessments tools in that platform. That platform does talk to our health home platform. Yay. So that's very exciting for us. And so the CANS does not determine eligibility in the program. Again, it's about acuity and it's about chronic conditions and appropriateness. But the CANS is completed within 30 days of entering the program so that you can, as a care manager, learn that story, get the information you need to get to determine the development of your plan of care and how you're going to move forward. It also determines our decision model, which we rudely called acuity and algorithm that John doesn't like. So that decides the payment for our care managements and also the level of care management intervention. So in 2019, we did what's called a consolidated children's waiver for home and community-based services. We took 6 children's waiver services and we consolidated them all into one. Again, this was the breaking down of silos. We heard from so many families that all the services in the waivers were not the same, and you can only be in one waiver at a time. And so if a family needed another service in a different waiver, they had to start the process all over again. And it was just very challenging, right? We were putting kids in boxes, right, and said, you have serious emotional disturbance and you can't have anything else, because if you have something else happening or you need something, then you have to go to a different waiver to get that. So families really vocalized with us how stressful and just difficult that was to navigate. So we consolidated these 6 waivers all into one in 2019. And then we said, well, why would we use another assessments tool? That would be silly. Care management for the waiver is our health home program. And so we are using the CANS as well. We developed like a subset of questions from our CANS that determines our decision model. And that does determine whether or not a child or a youth is eligible. So that part of the CANS does do that. To make a child eligible for the program. And that is also the tool that we use to develop the service plan for the waiver as well. And I'm not sure if everybody is aware of what home and community-based services is, but again, it's for those high needs, high risk children in a certain category of service. And it's really to help the children remain in their home, in their community, or if they are at an institutional level of care, hospital, residential care, then to get them back home. So those services to assist them in coming back home. And then we have what we call, it's a CMS federal language of target population. So the 4 populations of kids for our waiver, when we merged all 6, is serious emotional disturbance, the medically fragile, the developmental disability and medically fragile, and then developmental disability and in foster care. So we took our 6 waivers and we literally put them into one. So these populations were already in one of those 6 waivers. And as I mentioned, then we are using the CANs for that assessment tool. So that health home care manager, when you enroll the child in the health home program, they complete our full CANs. And as I mentioned, it determines not only their payment for intervention level of high, medium, and low, based on that acuity score, so to speak, it determines how much minimum level of service or intervention they have to provide. And then if they think a child is appropriate and would be eligible for our home and community-based waiver, then they complete a subset of the CANS questions and other screening items that they need to complete. So in 2016, when we launched this and we developed this CANS New York, we had promised stakeholders at the time that we would evaluate the data and see how the tool was working because it was brand new and it did impact payment. And so folks were really concerned about, well, is this tool going to work? What is this going to do for us? And so we had promised that we would review the tool. We were hoping to get our waiver, our consolidated waiver of the children's waiver, launched in 2017. That implementation date got pushed 3 times, and we launched in 2019. So it was really hard to try to assess the entire tool and how it was working for the continuum of care because we hadn't launched part of our, our system redesign. But in 2017 through 19, we were, obviously trying to get feedback. We had the Parade Foundation, a contract to, provide training and a certification. And, so we were really trying to figure out, is the tool working? Is it not? We had coaches. We were trying to listen to the feedback. And we really wanted to put a lot of effort into training and education to make sure the care managers were scoring the items correctly, as well as making sure they understood what they needed to do in relationship to their care management services. So we spent a lot of time doing that in the beginning. And then COVID hit, right? Not even a year after our waiver was consolidated. And it was a huge transformation for our providers as well as for families because we had to transition all these children into this new waiver as well as all the providers in identifying how the services would be done. And so we're going to look at how this tool is working, but then COVID hit. So in 21-22, we sat down with a lot of folks on John's team, and we said, we need to know if this whole algorithm is working, are people scoring things correctly, and are we telling care managers what the level of service is. We were getting lots of feedback from our care managers because you'll see in the next slide, that the acuity level and the amount of intervention were similar for medium and high. And so they're like, well, what's the difference between a medium and a high kid? What am I supposed to be doing? And so we were trying in the beginning to have a floor, a minimum standard, and then based on person-centered, right, or the needs of the child and the family, they could do more services. But that was really hard for them because, again, it was new. And when you connect those types of things to payment, right, they want to get paid and they want to know how to do that to get paid. So in hindsight, I think one of our lessons learned is don't link your assessment to payment. Right? It's a bad motivator. So we've been doing some talking about how we might change some of that. But I think we've been doing a lot of work. We got our stakeholders back together, and we actually are streamlining our tool. We're reducing the number of items because we got feedback that there's these 2 similar items. How do I score both of them? So we did a lot of looking at the items, the language, and then just all the data. Olga's going to be coming up here, the amount of data that they looked at to see, what was really working, not working, what was happening that the care managers were doing. And so again, we looked at all of that data, and then we are now looking at, well, what does the intervention look like? If you have a high needs kid versus a medium or low needs kid, what does that look like? And what should you be doing for that child or family? And so I'm very excited to announce that in November 14th to be exact, we are launching our CANS 2.0, which is, I think, going to be amazing. With all the data and research. And our University of Kentucky folks are doing these amazing videos and things to just, break it down in simple terms for the public and for care managers about what the change is and how it's going to really help children and families in the end. And so, as I mentioned, one of our challenges was this CANS tool for the health home program was connected to payment. So a monthly payment per month. So we had low, medium, and highs. And as you can see there, when I listed those 6 core services, they had to do 1 core service. It could be a telephone call. That was the minimum for the family in low acuity. And then medium and high, they needed 2 core services. 1 had to be an in-person, face-to-face contact. And folks look at this sometimes and they go, that's it? That's all you got to do to get paid? And because we had so many care coordination programs before the health home started, we just went around the state and we heard so much feedback. They're like, well, in this, in the Office of Mental Health, they require you to do 5 home visits. And, in the Office of Children and Family Services for Child Welfare, they make you do 3 home visits. And then we're like, why? Like, what was the rationale? And nobody really could tell us what the rationale was. It was just a policy. So we took all those care management agencies when we built the health home, and they became health home care managers. And can you imagine all that? They came from different policies, different backgrounds. We're like, what are we going to do? And we said, well, you're care managers. You're going to be trained properly. And why aren't we giving as much services that the family needs and wants? Why are we mandating you do 5, 6, whatever it is? So what we tried to do in the health home program was say, this is the minimum standard. You can go above and beyond based on the needs of the family. And this is really relevant to the data that you'll see. So the CANS is supposed to tell you, obviously if you're high, we expect you to do more interventions than a low kid, right? A low kid's kind of like a maintenance. And I'm sure all of you know, right? Kids move from acuity, right? Our CANS was being done every 6 months. We just moved it a year ago to annual because our assessment for our waiver is also annual, and we wanted those to match. So that was what our acuity was. And now with our new decision model, aren't you proud that I'm saying that? So as you can see, we are also changing the wording from low, medium, and high to standard, intense, and complex. We think this is going to really help care managers understand and try to get away from the payment and really thinking about what the kid is, how the kid was assessed. We will be changing the number of core services that match that based upon the data. As well. So you can see at the bottom there, we're changing the number of core services and interventions that need to happen based, again, upon the data. So we're really excited that this is all data-driven and we can explain it. That's always good when you can explain it. And then I think this is really going to meet the needs of care managers because, again, they were like, what's the difference between a medium and high? Now we can say this is the difference, right? This is the difference between that standardized kid or that low kid versus that really complex kid. And because you have a complex kid, based on your assessment, hearing the story of the family, then you should know you're going to do more core services, more intervention, more work, and you will get that higher payment. But that is what you're going to do to like manage your caseload, which I think is really exciting because it's all data driven. And then I think I'm turning it over to my friend here.
Thank you very much, Colette. Hi, everyone. My name is Olga. My last name, somebody last week, whenever they looked at my last name, said that it looks like a temporary password that Google suggests to you. So I said, I'm definitely going to use that line. I am a research assistant professor at the University of Kentucky, and I joined the EVE Center a couple of years ago. Before I joined the center, I was a regular teaching faculty at the University of Kentucky tenure track, and my research was focused primarily on genetics. So I have a master's in mathematics, I have a PhD in statistics, and I was doing a lot of work in genetic epidemiology. Now, you would think genetic epidemiology in cans, like that sounds very different. Actually, it's not, because in genetics, the data that we look at, it's number of either major or minor alleles at the genetic position, which is a count, 0, 1, or 2. And with the cans, we have a rating, which once again, a count of either 0, 1, 2, or 3. So the data looks very, very similar. Now, the reason there's this a little bit of a digression. Our previous speaker said that in academia, it takes on an average 17 years to see 14% of your research implemented. I very much agree with that statement because I felt like all of my work that I did in genetics, it was just like I was sending signals somewhere to like, I don't know, aliens. I would never hear anything back from them ever. And this work with Colette in New York, that was the most gratifying experience that I've ever had in academia. Yes, thank you so much. Because we worked very hard, both ends. I mean, we had weekly meetings with Colette, which was a lot. But at the same time, you do see your work come to fruition and immediate implementation. And it was, as I said, very gratifying experience. Thank you. So let me, before I start, I also have to say that I feel a little bit like an imposter because none of the work that I'm going to present is actually done by me. It's done by my wonderful team. So the next set of slides, Sharon Tan, he's the one who actually produced them. That also Michaela Boyd, who had a presentation yesterday, Gavin, who will have a presentation on Tuesday, Darren, Wiley, Hey Yoon, Jordan is somewhere here. She's working with Scott, who is our next keynote speaker. So thank you very much. This work is not done by me. It's done by wonderful people that I'm so privileged to work with. Okay, so how did we start reviewing the tool? We start by, first of all, evaluating how does the acuity algorithm performs. And acuity, as something that Colette was saying, was based on the CANS assessment. So you would think that similar CANS assessments should lead to similar acuity levels. However, within CANS 1.0, we had like over 100 items. So how can you simultaneously consider 100 items, say for two different children, and say that, you know, the two assessments are similar or dissimilar to one another? It's kind of hard to do. So we used a technique, it's called multi-dimensional scaling or principal component analysis, and this plot kind of explains what it's trying to do. So assume that instead of having hundreds of items rating, we only have ratings on 3 items. So here I I chose problematic social behavior, living situation, and social functioning. This choice is arbitrary. So I just pulled 3 items. Then on these 3 items, children are rated. So for example, the dots say on the lower left part of the cube, it's a blue one, right by 1 on the y-axis. What that means is that that particular individual has a rating on 1 on problematic social behavior, a rating of 0 on the living situation, and also a rating of 0 on the social functioning, which is this depth or a z-axis. So if we have ratings over 3 items, each single child has a set of 3 measurements. And those 3 measurements can be thought as coordinates in a 3-dimensional space, like in a cube. Now, okay. Thank you. Oh, there we go. Thank you. Now, also notice in that cube, so each single point represents an assessment of a child, but then I also kind of like created as a pinpoint, like vertical lines going down. So what it means is that this 3-dimensional cloud in a cube, we can project on the floor and we can see, once again, assessments over 3 items, but in a 2D plot. So here, what you saw on the previous one, it's a cube, and now just project it on the floor. Now you can generalize this idea. Just like where you have 3 items that you're assessing, and they are coordinates in a 3-dimensional space, if you have 100 items, then per child you have a coordinate in a 100-dimensional space. I know it's very hard to visualize, but yes, 100-dimensional space. However, what we can do, we can keep on projecting that multidimensional space down and down and down. And finally, we once again have a projection on the floor in a 2D space. And that's what we did with the Kansas assessments in New York. So we've been referring to this plot for the last half a year as a plot of a fish. However, it is not a fish. Every point in this plot represents an assessment of a child across multiple items. If the 2 points are close to one another in this 2D projection, that means that their KENS ratings across all of the items that we have were similar to one another. So we were able to kind of measure the proximity or the similarity among KENS assessments. And here you should see about 3,000 points because it's a projection of assessments of about 3,000 children. Okay, so then while revising the tool, what we did next, we color-coded that fish by the acuity that were assigned to that child after that KENS assessment. So it's exactly the same fish as in the previous slide, but just we added color. And what you can immediately see, like up on the top, on the fin of a fish, that we have children that I told you proximity in this 2D space means that the KENS assessment is similar. However, they are colored different colors. They're colored as some of them as pink, which means that they were assigned a low acuity level. Some of them are colored as green, which means they were given medium acuity level, and some of them are blue. So there is a lot of bleeding of colors in one another in that fish, which means that there was sort of like a lack of association between the complexity of children's need on the KENS assessment and the acuity level that were given to them. Whenever we start revising the tool for the acuity, our first goal was to make sure that if we were to look at the fish and color-code it by the acuity levels, we would minimize that bleeding of colors. And that's what we did. So once we revise the algorithm and assign the new 3 levels of acuity and project it down to the 2D, now you can see that there is a much more clear boundary between children. I did not label axes in this plot as an X or a Y axis because clearly this is not what they are, because we started in this multidimensional space and then we were reducing dimensionality. However, those axes do have some interpretation. And here we called the acuity for, this is, I have to say, all children 6 to 21. We called it a one-dimensional problem. Why? So here an x-axis roughly represents the complexity of children's needs. If you move west on this plot, these are the children that have very low level of need, hence they're colored pink, and they're they're called to be low acuity level. And as we travel east, the total complexity of needs, so the total number of actionable needs increases. So there is this interpretation of traveling along the x-axis. And if we were trying to design a decision support model to, as a new kid comes over and has a CANS assessment, a kid will fall somewhere on that plot. It would be yet another dot on that fish. And we can almost slice that fish vertically to decide which acuity level should be assigned to that child. So because it only needs a slice in one direction to decide the level of acuity, we call that problem one-dimensional. And we design the decision support model by basically counting the number of actionable needs, because that's what drives the x-axis in this plot. I would say questions, but I would assume, yeah. Okay. Then we revised the acuity model for younger children as well. And here the problem was a little bit harder. It was two-dimensional, and I'll explain why it was two-dimensional in a second. So first of all, if on the previous plot we were looking at the fish, this is not a fish. I'm actually not sure how we used to call it, but this is the projection of CANS assessments of younger children. Once again, a proximity of 2 points on this plot means that the CANS assessments were similar to one another across all of the items. Once again, we then color-coded those points by the assigned acuity level, and yet again, we see a lot of bleeding of colors. Once again, we wanted to increase the level of separation, which we did, and we assigned these 3 new acuity levels. Now, the movement on an x-axis once again corresponds to the total level of needs. However, note that to separate, say, the pink region, you cannot just make one vertical cut. It requires 2 cuts. You have to go both vertically and horizontally to say that these children, they're pink, they're at the lowest level of need versus the greens. So designing a decision support model to assign a child a level of acuity among younger children was a little bit of a harder problem, because the algorithm had to account for this kind of two-dimensional nature of the separation on this plot. Okay, I have only 3 minutes left, so I will try to go very quickly about some additional work that we did that translated from working with New York, because this work was very inspirational and gave us many more other ideas. So with this color separation, say one of our team members is trying to predict or try to identify children in the system that do not have a reported, say, autism diagnosis or an ASD diagnosis, but they definitely present symptoms of an ASD. And that team member developed, well, actually two of them, Michaela yesterday presented her result. They developed a neural network to identify those children that are likely to be an ASD case. Now, a neural net, everybody knows that it's a black box and it's a quite sensitive topic. So we just developed some algorithm that says that your child is an elevated risk of ASD. That's a very bold statement to make, right? We really, really need to make sure that our algorithm works. Now, how can we make sure that it works? We unfortunately did not have a clinician who can review all of our predicted cases, and this is thousands. Somebody suggested us to run our predictions versus some other algorithm prediction, which is, to me, it's like, okay, I'm comparing our black box to your black box. That doesn't really work. So we really thought that maybe we can use that idea of the projection and color separation. And if we were to have a method that can visually separate ASD children versus not ASD children, then we can use the same method to look at the predicted ASD versus not. And if we still see the separation, well, that means maybe our algorithm works. Now, guess what? Whenever we did it first time, this is what we saw. Here, once again, each single point represents a child, and color represents either presence or absence of ESD diagnosis. Do you see visually any separation? I certainly don't. This look like white noise to me. And why is it so? You remember in the previous slide, I told you that an x-axis roughly represents the total actionable needs. Well, ESD is not driven by total actionable needs. It's driven by a very specific set of items. And please come to this talk. It's today. Wiley will be talking about his work about creating an algorithm of actually visually separating the ESD versus not ESD children. So here the pink ones are the ESD diagnosed children, green one are not ESD diagnosed. As you can see, the separation is much better. The blue ones sprinkle in between are the predictions, and then he also color-coded a projection like that by the probability of ESD. So you can see a very nice linear pattern going from basically 0 for non-ESD children almost to 1% for those that do have a diagnosis. And we also have a work of Darren, who will also present today, who took a similar approach, but with a different purpose. He was looking at major depressive disorder, and he wanted to see an effect size of an intervention. Once again, whenever he initially did a projection with F33 diagnosis, it's all over the place, once again, because it's not driven by the total actionable needs. Then, as he was working on his method, he was able to get to that. That's a very, very strong separation. The children on the far right, they're primarily red. These are the children that are doing well in terms of the depression. They do not have any depressive symptoms. On the lower left, although it kind of looks like it's contaminated with red, it's just because on this plot, red was plotted on top of blue. It's really predominantly blue. So those are the children that depressed, and children that are the up top, like the top blue, they're depressed and also have suicidal ideation. And then he was able to measure the effect size of the intervention as the movement of those children from being in the area of depressed and suicidal to the area of doing well. So please come see his talk as well. So thank you very much.